Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I have a very special guest. We have Colonel Shackelford from the JTS. How are you doing, Stacey?
Hey, good afternoon. How are you doing?
I'm doing very well. For anybody who lives under a rock and has not heard of your name, would you please introduce yourself?
Sure. So I'm Colonel Stacey Shackelford. I'm a trauma surgeon and currently serving as the chief of the Joint Trauma System down here in San Antonio, Texas.
So absolutely very excited to have you on here today because we're talking about a pretty difficult situation, which is we're talking about abdominal trauma and probably more specifically exsanguinating hemorrhage from that trauma. So we're talking about big bleeds today. Fairly recently, they came out with the SOCOM paper, and when was that? 2012. They had the death on the battlefield from Estridge, and
yep.
I would like to kind of go over some of those numbers so we know, I guess, exactly what we're talking about.
Okay, yeah, very good. Starting with Colonel Eastridge's study back in 2012, this was death on the battlefield, 2001 to 2011, and they looked at mortalities, in particular casualties that died before they got to the hospital, and or KIAs. And trying to just really look at how can we save more lives on the battlefield. And the way they really did this study is they were trying to really look at like all the possible future ways that we could potentially address saving lives on the battlefield, and not necessarily limited to current technology. And so just kind of summarize those numbers. In general, they did find that about close to 90% of the casualties died before reaching a surgical hospital or a surgical capability. And then out of those that died pre-hospital, close to 90% of those died from bleeding. And when you start breaking down the bleeding sites, is when you really look at, what can we do more to save those folks. And it's kind of impressive of those patients who had potentially survivable injuries that died of hemorrhage. 2/3 were from torso hemorrhage. And then, let's see, I think there were 13% died from extremity hemorrhage and 19% from junctional hemorrhage. We could break down even more the truncal hemorrhage. 1/3 of those were thoracic and 2/3 abdominal or pelvis.
Right. So the abdominal injuries, clearly it's a large segment of the potentially survivable casualties.
Yes.
Yeah. So I guess, right now I'm fairly limited. I can do pressure dressings, etc. I can give blood, I can give TXA, I can give calcium. That's really about it that I have in my toolkit right now. Is there anything else that I could or should be doing?
So that's a good question, because could and should are definitely two different things. And then, kind of just to bring in a little bit of additional data to help us answer that question. There was a more recent study looking at fatalities in SOCOM. And this is also done by the Armed Forces Medical Examiner System in collaboration with the Joint Trauma System. And they looked at all the SOCOM fatalities from 2001 to 2018, of which there were 369. But this study was done a little bit differently, and they actually looked at the difference between survivable injuries which is similar to what Easteridge looked at. But then they also tried to bring in some component of the operational scenario, and they talked about preventable deaths. So it would be possible to have a survivable injury, but if the military situation or the scenario was such that there was really no way to deliver care to that person, then that would be defined as an unpreventable death.
Mm-hmm.
And so in this study, they found, again, about a quarter or so of the deaths were potentially survivable injuries, but then only about close to 7%, 6.8% had a potentially preventable or preventable death. And so that really kind of brings it into perspective that, there's a lot going on the battlefield, right, besides just taking care of medicine, which, you guys know obviously better than anybody, but just quantifies it better that, of all of the potentially survivable, in that study, they only thought that about a fourth of them, could have really been prevented through, the medical care, and the rest of it was, inhibited due to enemy activity, weather, whatever was constraining them.
Right. That's definitely a very good point, and hopefully that kind of continues in other research, is adding some kind of tactical component to that, as we look forward to things.
Right.
It's going to be a great big factor.
But on the other hand, like when you're trying to think about, okay, what are we really interested in? What can I do today? Yes, of course we're interested in that. But we're also interested in what could we do in the future, from a research perspective and a development perspective, where can we go in the future? Right. And so, from that standpoint, you don't want to limit yourself to what you can do today.
Of course.
So your question was kind of like, what else can you do besides, advanced pre-hospital care? The options pretty well, but we talk about REBOA. We talk about sort of the next generation REBOA, which is a flow-through catheter, XLAP or preperitoneal packing, like sort of surgical damage control, surgical interventions. And then I wouldn't take abdominal aortic tourniquet completely off the table. I am intrigued by the role that device could play in pre-hospital management of torso hemorrhage. And I'm also sort of discouraged by the lack of data that we have on it. So it's difficult for me to, really make any definitive comments, but I do have some ideas for it.
Okay. The AHAT, I think it seems, pretty simple. Essentially, it's a big tourniquet. You put it around the abdomen, pushes pressure on the abdominal aorta, cutting off all the circulation below that. Roughly, I think that would be zone 3.
Yeah, it's kind of like a zone 3 REBOA. And then, it can't stay on very long, just like a REBOA can't stay on long. For REBOA, we use 30 minutes is really the cutoff. You can maybe extend it a little bit longer, but you're really pushing it. That would be for a zone 1 REBOA. A zone 3 REBOA can stay up longer, but an abdominal aortic tourniquet, I would think of it as a very, very temporizing solution. Things we don't know about it, and the thing that, the reason why we didn't recommend it from TC3 in the first place is, bleeding upstream of where you put the AHAT. We don't really know what happens with that. It's not really like putting on an extremity tourniquet where, it's bleeding into the open air.
Mm-hmm.
If you put a tourniquet distal to an extremity wound, it will definitely increase bleeding from that wound. But if you're, say, bleeding from the liver, and I put a AHAT, below that, but it's in a contained space inside the abdomen, which is basically, compressing that entire space. So maybe it will help compress the liver, even if it's below that. However, I do know that if there's a hole in a diaphragm, it would definitely decompress into the chest. So
Right.
these are all the things that are very, difficult to know really what the role of the AHAT would be, or really honestly what's going to happen if you put it on.
Right. But I mean, something like that, I think we're definitely pretty used to. Now, especially lately, they've been talking a lot about REBOA and even at least retroperitoneal packing. So a little bit more, or definitely more surgical, I guess, in technique. I guess, can you tell me a little bit, at least about the retroperitoneal packing?
Right. So retroperitoneal packing is really only for pelvic fracture. So if you have a pretty bad pelvic fracture that's bleeding into the retroperitoneum, maybe there could be some type of like penetrating trauma where it transected the internal iliac artery or something like that, but it would be a very difficult to diagnose, that problem.
Right.
And so primarily we're talking about pelvic fractures, and you basically make an incision below the umbilicus down to the pubic symphysis, and then you open up through the fascia, but not through the peritoneum.
Mm-hmm.
And so you try to leave the peritoneal layer intact, and then you just dissect the peritoneum down from the abdominal wall all the way around till you get down to the sacrum, and then you shove like 3 laps on either side. So it's like 6 lap sponges.
Mm-hmm.
It's, not a super easy thing to do, especially if the patient is not completely anesthetized, which means they're actually breathing on their own.
Right.
If they're not chemically paralyzed, they're going to have a lot of muscle tone. And especially if you're talking about a warrior, they're going to have like significant muscle tone. That's going to make that pretty hard. But on the other hand, I feel like it would be sort of not that risky that you would necessarily risk making them a lot worse, but honestly, very challenging to think about doing that in someone that wasn't under like a complete general anesthetic with muscle paralysis.
Okay. I mean, is that fairly, the way you describe it sounds pretty easy. What kind of, I guess, training goes into teaching your residents that?
It is interesting. I heard my friend from Israel was over here recently, Brigadier General Glasberg, and he likes to say, why do we send surgeons, forward? And he's like, it's not to do surgery, it's to make better decisions. And so he looks at, and so honestly, the difficult part about all of these procedures is like deciding when to do it. And then when you do decide to do it, it's kind of like managing the situation so that everything else that needs to happen in order to keep the patient alive while you, surgeon, are doing that procedure is an extremely complex environment. And so you're talking about, all right, someone needs to manage the airway and the sedation and the muscle paralysis. And then someone else needs to kind of like manage the IV access and, getting all the blood transfused. Whereas probably there's someone else that's not even on the patient that's getting the blood to you
Right.
from wherever it's coming from. Especially if we're talking about walking blood bank, there's another level of complexity there. And then someone assisting the individual who's doing the procedure. So when you kind of start adding up the number of things that need to happen simultaneously, now you're talking about like pretty big commitment of resources there into one individual. So so it has to be like the situation has to be able to support that, and then it has to be like a team of individuals, and one of them has to have some pretty good surgical skills, while the other ones have to have some pretty good resuscitation skills.
Right. And that's definitely something I think guys don't necessarily think of, is all the things that have to take place before an intervention such as this is going to have to happen. You're not hood sliding in and then throwing a Reboa catheter, offhand, into the place and saving the day. Somebody's going to have to, you got to get to him. You got to get to the patient. You got to start your march. You got to find the actual bleeds. Start treating as best you can. Somebody's got to get access. Somebody's got to start spiking blood. I would imagine an abdominal, injury such as that you're talking about doing Reboa, non-compressible hemorrhage or even retroperitoneal packing is probably a significant amount of blood.
Yeah. I mean, I think it's hard to quantify, but it's probably a minimum of 6 units of blood, upwards of I mean, I would say 6 to 20 would be like somewhere in the realistic range. We've definitely had, surgical patients that had upwards of 100 units of blood, but in that, that would be like a crazy injury that you wouldn't really think of as being survivable in that scenario if
Right.
Weren't at a pretty advanced surgical capability. So I think between 6 and 20 units would be the amount you'd be talking about.
That you would have to have available to do this procedure?
Right. Yes.
Okay. Just out of a quick tangent, I guess more chasing that down. I guess, obviously you've deployed downrange before. You've seen these trauma patients. You've dealt with those trauma patients multiple times over. I guess how soon are we talking about within doctrinal timelines as far as the casualty's been injured, the time he gets to you, you're now having to resuscitate with, up to 20 units easily? Or it's an easy 20 units for that patient, I guess. He's lost that much blood that quickly.
Right. Yeah. Well, part of that comes from, and this kind of gets into the question of, doing an XLAP pre-hospital, because, or, at an earlier stage before they get to a robust surgical capability. As the, patient is initially stabilized, and as we've looked at these times, if someone is basically bleeding to death from an injury that is survivable, that person probably needs to get blood on board within about 30 minutes.
Yeah.
Now there could be someone that's bleeding faster, but a lot of those injuries are non-survivable. So our planning factor is about 30 minutes for transfusion, and that can actually buy them a fair bit of time. We don't know how much, but there's been some outlying cases where they've bought them several hours. But for the most part, you need to get to a surgical team within about 60 minutes if you don't have pre-hospital transfusion. If you do, that probably buys you another 30 to 60 minutes, relatively speaking. And then at that point, you're really looking at the mortality will increase quite a bit if you're not able to, get in there and stop the bleeding at that point.
Right.
But the thing is, like, once you open the abdomen, any degree of tamponade that's sort of partially controlling the bleeding is now completely gone. And that's usually at the point where we really are really starting to dump in the blood transfusion, is at the time when the surgeon is directly addressing, finding the bleeding site and controlling the bleeding site. That is, when a lot of the transfusions end up going in. I mean, when we put in a Reboa, that does potentially have the possibility of getting quicker hemorrhage control, and then may ultimately save blood products. Know that there's a lot of data to show that yet, but it does, I think anecdotally we feel like it does, help us manage the blood products easier, get it stopped sooner.
Yeah, I mean, that definitely makes sense. Turn the faucet off will help save, the amount of units you end up having to give somebody, or at least hopefully reduce the amount, just like, TXA, just like calcium, all those, they were all supposed to, reduce the amount of transfused fluids.
Yep.
So,
Yeah, whole blood, calcium, TXA, even just warming the patient, definitely has a role. Kind of like the other thing I've been kind of thinking of is that, someone that comes in with a gunshot wound to the torso, it's actually quite difficult to know where the actual injury is. And so you do have to be very, very skilled with ultrasound to begin to figure that out. That should be able to narrow it down to either the right chest, the left chest, or the abdomen / pelvis, kind of being one, space.
right.
And then a retroperitoneum, you were not going to be able to see on ultrasound. But so that, and then to actually, if you kind of like, that will lead you to, whether you can safely put in a Reboa, or whether you should do an X-lap versus a thoracotomy, which space you can even open. And interestingly, even if you have all of that, a third of the time you'll be wrong if there's a gunshot wound that's somewhere in the upper abdomen or lower chest.
Right.
As far as if the injury is actually in the chest, but you open the abdomen, now you're in the wrong space.
Right.
But like what we say is that for surgical decision making, make a decision, make an incision. If it's the wrong decision, make another incision. So, sometimes you end up going into the abdomen and then finding out you need to be in the chest, or vice versa.
Right.
Yeah.
I'm sure that's probably super common, especially when you're talking, like you said, high abdomen, low chest, that diaphragm domed around, in just one straight bullet track, which usually they're not straight. It could be in both in the same shot.
Right. Absolutely. And sometimes, if say like the liver is injured, but there's a hole in the diaphragm, then all the blood will kind of get sucked into the chest because it's a negative pressure area. So you can be kind of fooled as to, where the most blood is not necessarily where the bleeding is coming from.
So after having said all that, if you were put in charge to fix this problem of abdominal trauma, I guess where would you start focusing? Where would you put your effort?
So I think there's a couple of things. One, I would want to, the basics, I learned this, the Rangers always talk about this, especially, the basics are like essential. So you have to be like incredibly good at stopping external hemorrhage. You have to have a really good feel for how to control junctional hemorrhage, how to, get a tourniquet on quickly and perfectly, and and then to be able to get blood on board, whatever your plan is, whether you're carrying cold stored, or if you're walking blood bank as your plan. Like that is like the most important life-saving skills you can have. Managing airways is probably up there somewhere close to the top, but given the number of hemorrhagic deaths, that takes priority. I've also thought about, there is a good number of these torso deaths coming from the chest, and I'm actually curious about the role of chest tubes. I think it's underemphasized, but actually putting in the chest tube and re-inflating the lung, by expanding that lung, it actually compresses some of the bleeding, and that can actually reduce chest hemorrhage. So I do think there may be potentially a larger role for chest tubes. It's hard to quantify that, especially if you may or may not have suction and you're just relying on like a Heimlich valve. But if a Heimlich valve is successful in re-expanding the lung, that should contribute to reducing bleeding there. So I think that's a good skill to have. And then even looking for better material solutions so that it's easier to put in a chest tube. I think that would be a focus. I would love to have more animal experience, like experimental evidence from animal studies looking at the effect of an abdominal aortic tourniquet. So, that would be my request, would be to really study that. And then to really look at the role of resuscitation teams. I think certainly these advanced resuscitation skills, a bunch of things need to happen simultaneously, along with really good ultrasound skills and advanced decision making. And so I think the role of a team of people that maybe they're not surgical exactly, but they can do some of these more advanced procedures. I think that is probably one of the bridges to surgery. And then they talk about, if you think like Jamie Riesberg likes to say, if you think you need a surgeon on the battlefield, put one there.
Right.
So
yep.
maybe we need more surgeons, but even single surgeon teams have difficulty managing any of the really more complex injuries, honestly. And so it's definitely a spectrum.
Yeah, especially when you're talking about simultaneously having a anesthetist or resuscitationist and a surgeon at a minimum, just keeping this guy alive long enough, the amount of resources, that to me, it definitely is not screaming, 18 Delta. You're screaming, some kind of sauce team or sort team or somebody like that.
Yeah, either that or maybe like about 18 Deltas that have trained in trauma centers
right
together. So
then we would equal one medic.
I wouldn't put it beyond 18 Deltas, but it is really just a very, very unified team effort that goes into that sort of advanced resuscitation. Anecdotally, like even from the cases that I've had, I can think of a few cases where we basically just opened the abdomen and we're like, oh, he's bleeding from this little thing on the omentum or this little tiny edge of the liver, and you just like put a clamp on it. And so, you could totally have a situation where you did that and you just got very lucky. But you probably have equally or greater chance of increasing the bleeding and making them worse. And you just don't know which is which. So
right. And is that because you're unroofing the hematoma there?
Yeah, releasing any amount of tamponade that there is, and getting into a bleeding site that you can't see where it's coming from, because you don't have good exposure, and then not having enough blood products to keep up, and simultaneously trying to control the airway and all of that. So and then the last thing I would say is that all of this it's really not that complicated, but it does require just exposure to this type of patients and decision making on an ongoing basis. And so I think we're whatever we could do to get more clinical time for our medics, whether it's, hire someone to see the outpatient clinic while they're in garrison so that they can spend more time, instead of seeing clinic, to do time in the trauma center, just whatever sort of outside the box solutions that you can think of that might break some of these guys away from any sort of routine duties so that they can actually get more time in the trauma center. I think that would be incredibly valued in time well spent.
Yeah, absolutely. Since this is a prolonged field care podcast, let's just assume that we got lucky and we were able to stop the bleeding from an abdominal trauma, what kind of aftercare or complications can result from that?
So obviously a lot. Just kind of think about things like associated injuries, bowel injuries potentially, pancreas, kidney, etc. You have an open abdomen, so you need to somehow manage that. You can temporarily manage it with like a large Ioban plastic, which is what we typically use, or something like a Bogota bag, which is plastic sewed to the skin edges. And, helping just kind of keep the guts in place. Right. Then you have a guy with an open abdomen, probably can't breathe very well. And so you need to be thinking about how can you manage the airway in that person. Typically, they require ongoing resuscitation. So you're going to be looking at needing to give them IV fluids to sustain them. They're probably not going to be drinking water. So even just maintenance IV fluids and, initial resuscitation fluids. Feeding the individual, kidney failure, rhabdo from if they had any degree of ischemia, like if they had a tourniquet up or a Reboa or anything that cut off circulation to part of their body and then was reperfused, that can lead to rhabdo. Any infectious complication that you can think of possibly as well. And then, getting to the point of like, you really have a lot of problems with just managing their electrolytes. And so like we're constantly, if they're in the ICU, like every hour for the, first few hours, and then maybe every 4 hours, and then maybe every 6 hours, checking their electrolyte levels, giving them potassium, magnesium, phosphorus, adjusting their ventilator to make sure that their oxygen and CO2 levels are, appropriate. And so all of that kind of gets into like, you really need a lab capability of some sort for sure. And then, replacement electrolytes, particularly calcium and potassium, I think are the big ones that get replaced the most. But then you think about giving potassium, you have to be very, very careful about not giving it too fast and stopping their heart. So blood clots, I don't know, it is pretty complex for that. And I think, in the immediate post op period, it comes down to resuscitation, checking labs, and managing their hypoxia.
Vent management.
The biggest challenges. Yeah.
Yeah. Would you think, as kind of a general rule, at least in the ICU, hospital-based medicine, these bad abdominal traumas, are they usually tubed and vented as just a kind of a general rule to help with that oxygenation?
Usually. It's not like 100%.
Right.
So, and it kind of also depends on how much blood they got. The more blood they got, usually the more inflammatory reaction and the more sort of third spacing they'll have and the more hypoxia. So, and sometimes you'll just go in there and it's like, they just had a bowel injury. You'll fix that, take it out, put it back together, that type of thing.
Right.
And then you make a pretty quick recovery, but that'd be a pretty challenging operation for an 18 Delta, to do a bowel resection. So,
yeah.
But, you practice it a few times, I'm sure you can do it. But
yeah, I saw it on YouTube, so I'm pretty confident.
Totally. You can totally do it on YouTube.
Yeah. That's next YouTube video, abdominal trauma. But as we're getting close to the end here, Stacey, is there anything else that you would like to kind of educate somebody on, or any advice you would have for somebody who has to deal with, a patient like this?
You're right now that our best chance of saving a patient with abdominal trauma is to really focus on everything that can sustain their coagulation. So whole blood, yes, but even more so than cold whole blood, warm, fresh whole blood is probably going to be the best thing for, clotting, for controlling your own hemorrhage. And then the 2 gram TXA dose, yes. Any external hemorrhage, absolutely get that under control. And, calcium is in there as well to help improve those coagulation as well. If you have FDP, that could actually potentially also improve your coagulation, but probably not as well as fresh whole blood. And then don't forget about just the role of warming the patient. We know that hypothermia is contributes to the triad of death just by making you more coagulopathic. So just getting them warmed can help. And then there might be some type of role in terms of positioning the patient. And it's just it's hard to know, but if let's say you're bleeding from the neck, if you sit the patient like 30 degrees elevated, that will dramatically decrease the bleeding from the neck. So then you kind of have to think, well, if they're bleeding on the right side of the abdomen, maybe putting that side up might make a difference, but it's hard to know for sure if you're just looking at one bullet hole where their bleeding side is from. But sometimes you might have an idea if you think they're bleeding in the right chest, or even just in the chest. You might elevate their head to help reduce the pressure in that part of the body. So that might be applicable to certain individuals, depending on what's going on.
Mm-hmm. Cool.
And then, and I also mentioned the part about, a chest tube getting the lung reinflated. That may actually have a role in controlling chest hemorrhage.
Mm-hmm. Cool. Hey, thank you very much, Stacey. I really appreciate it.
Yeah, you bet. And I hope all of you guys out there never end up having to get in a situation like that. But if you do find yourself having facing a really, really difficult decision, maybe also telemedicine consult might give you some additional advice that can help you in your decision making. But a lot of it comes down to experience. And, I think that experience probably gained by taking care of real world patients. So the more you can do that, the better it is.
Outstanding. Hey, thank you again.
All right. Right on. Thanks, guys.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.